This is a presentation on antipsychotics and dementia by Erin Sheehan. Next slide. Dementia is a broad term or an umbrella term for symptoms associated with brain disease that affect a patient's function and memory. The term can be used to describe the symptoms of a group of more than 100 conditions that impair memory, behaviors, and thinking. The most common causes of dementia are outlined in this slide. Alzheimer's disease is the most common form of dementia and the most well-known. Another type that is very common is dementia with Lewy bodies, which accounts for about 15% of all cases. It's associated with abnormal brain cells. In my paper, I talk a bit about vascular dementia. It's the second most common form of dementia, which accounts for about 20% of cases. It occurs through a reduced blood supply and usually due to a stroke or prolonged increased blood pressure. Alcohol-related dementia can be very common, especially in elderly psychiatric patients. Parkinson's disease accounts for about 5% of dementia patients, and then there are many other types. Next slide. Patients around the globe continue to live to longer ages, and dementia is becoming more prevalent every year. In the year 2000, there were approximately 25 million patients with dementia around the world. That number is expected to increase every year and is expected to be around 63 million by the year 2030. With this many patients living this long and having more symptoms of dementia, we're going to continue to need treatments and research to find out the best way to take care of these patients. Next slide. Patients with dementia often experience behavioral and psychological symptoms of dementia. About 90% of patients with dementia experience these symptoms. They can be described in the slide below. There are mild impairments, moderate impairments, and severe impairments. They all affect, as this picture shows, the intelligence, judgment, behavior, memory, and language. Some of the more severe symptoms of dementia that need to be treated with medications that are distressing to patients and families are agitation, psychosis, delusions, aggressive behavior, and these are the ones that are typically the hardest to manage. Next slide. Antipsychotic medications are a group of drugs that affect the neurotransmitters in the brain. There are two classes of antipsychotics, typical and atypical. They're also called first-generation and second-generation antipsychotics. The typical or first-generation antipsychotics are listed on the left, and some common ones are Haldol, Thorazine, Prolixin, Loxetine, Trilofan, and Mellaril. The atypical are listed on the right, and common ones that are used are Abilify, Clozaril, Zyprexa, Seroquel, Risperdal, and Geodon. The typical antipsychotics became available in the 1950s, and their side effect profile is noted for extrapyramidal side effects, or EPS, and tardive dyskinesia, TD. The atypical antipsychotics became available in the 90s, and although they had less incidence of EPS and TD, they do have metabolic risks that can lead to weight gain, diabetes, and hyperlipidemia. Next slide. Antipsychotics, the first and second generation, were approved for use in schizophrenia and also for use in mania associated with bipolar disorder. Neither of these types of antipsychotics are approved for use in dementia or behavioral symptoms of dementia. They have had 2 FDA warnings put out about them that they are actually dangerous for this population. However, they continue to be widely prescribed. The reason for this is that there are no medications that are approved for these symptoms in dementia, and oftentimes these symptoms can be dangerous for patients, and since they mimic some of the symptoms in schizophrenia and mania, such as agitation, aggression, psychosis, and delusions, doctors tend to prescribe them. The problem is that sometimes they're being overprescribed when it's really not appropriate. So this slide goes over some of the reasons that it would not be appropriate to prescribe an antipsychotic to a patient with dementia. And basically it's to, you shouldn't use them to restrain the patients. You shouldn't use them if a patient is being avoidant or is being uncooperative or apathetic or having slight anxiety. They should really be restricted for use when the patient might be a danger to themselves or a danger to others or completely unmanageable. The first line treatment should always be non-pharmacological if possible, and we'll go a little bit further into that. But this just kind of lists all the reasons that you wouldn't prescribe an antipsychotic to a patient with dementia when you consider the risks that are associated with these medications. Next slide. There have been many large randomized controlled trials and systematic reviews done by the FDA and Medicare, Medicaid about antipsychotics and their risks associated with dementia patients. They've been tested a lot with atypical antipsychotics, Risperdal, Zyprexa, Seroquel, and Abilify have been tested more than any of the other medications in my search, and they're linked with increased risk of death and also increased risk of stroke. However, just because the typical antipsychotics haven't been tested as much on a large scale does not mean that they are safer. Actually, in the research that I did for this paper, all of the different studies and systematic reviews found that the use of typical antipsychotics were less helpful for the symptoms and more dangerous. In the study by Pratt, Rohead, Salter, and Ryan, it shows that there's 1 death associated with every 100 patients that might be using an atypical antipsychotic, but between 2 and 7 deaths for every patient using a typical antipsychotic. The risks of stroke, fracture, and pneumonia were also higher in typical antipsychotics, and they were higher in atypical antipsychotics than in placebos. So basically, you have higher risks for these with an atypical antipsychotic, but you would have even greater risks if you were taking a typical antipsychotic. Next slide. All of the studies that I synthesized for this paper were pretty much in agreement that typical antipsychotics should be avoided in dementia patients, and atypical antipsychotics, although they do have a lot of risks associated with prescribing, were indicated when the symptoms of dementia are moderate to severe. The most studied atypical antipsychotics were Risperdal, Zyprexa, Seroquel, and Abilify, and these dosages are listed on this table here for the maximum daily dosages that would be prescribed in dementia patients. The risks that are associated with them tend to be in the first few weeks of treatment, and also when they are prescribed in high dosages. So when treating the elderly, you don't want to go above these dosages because for many reasons, but they're at a higher risk for drug-to-drug interactions. They have age-related pharmacokinetic changes. They're already at a higher risk for death, stroke, pneumonia, fractures, as well as the regular side effects of these medications, which are EPS, metabolic symptoms, tardive dyskinesia, and weight gain, diabetes, things like that. So you really want to go low at the lowest possible dose to start, and then when you're titrating them up, go low and slow and not go above these daily dosages. Most of these medications don't show any benefits after 12 weeks of use, but one of the ones that was shown to be effective is Risperdal. And it sounds like it's a good choice because it's cost effective and one of the most effective for symptoms. It actually has been approved for use in England and Europe with patients with dementia, and it's generally well tolerated. Next slide. As we discussed, antipsychotics are an off-label treatment for dementia. There are no approved FDA medications for dementia symptoms. Therefore, we should always attempt to use a non-pharmacological treatment as the first line approach. There are many different ways that we can do this, but one of the main important things to do is to do a thorough assessment of the patient that's having any kind of symptoms like psychosis or agitation, because a lot of times there are medical reasons that they might be experiencing these symptoms. In dementia patients, a lot of times communication is difficult, and therefore they may not be able to tell you why they're, what's going on with them. So you always want to sort of assess them for pain control, for hunger, for infections, for uncontrolled medical symptoms, for any kind of sensory disturbances. If a patient is in pain, that can be causing their agitation. If a patient has an infection, that can cause delirium or psychosis. So you want to rule out UTIs, rule out tooth infections, rule out any kind of chest infection or pneumonia. You also, if they can't see or hear, they might need a new hearing aid, they might need new glasses. That could be causing them to be agitated. If their diabetes, if their sugars are uncontrolled, that can definitely cause them to have changes in their mood. If they're having trouble breathing, that can cause confusion. You can't be overstated the importance of checking all of these things before starting an antipsychotic, because oftentimes putting an antipsychotic on top of an infection or delirium or a patient in rhabdo can make their condition much worse. Next slide. We already discussed the reasons that you would and would not prescribe antipsychotics to patients with dementia, but just to review, if the symptoms are not persistent or distressing to the patient, then non-pharmacological treatments should be utilized. Watchful waiting can be helpful because oftentimes dementia symptoms may resolve themselves. Sometimes just in a few weeks without any medication or intervention at all, the symptoms may decrease or go away completely. Some alternative therapies for symptoms are brief social interactions, just spending time with the patient, engaging them in activities that they enjoy. Exercise can be a great release. Behavior plans with rewards and aromatherapy has been proven in studies to be effective in giving them pleasant activity choices, are all different non-pharmacological interventions that a systematic review found that could help these symptoms. Next slide. Now that I researched the risks associated with prescribing antipsychotics in dementia patients and some of the alternatives to these therapies, I wanted to see, where the most of the overprescribing was happening, and it seemed to be through several studies that it was in nursing homes. So one national qualitative descriptive study that used over 200 patients on antipsychotics in various nursing homes in 5 different areas of the country found that antipsychotics were often overprescribed and prescribed inappropriately, and that staff frequently couldn't identify reasonable rationales for the prescription of these medications. There was evidence in these nursing homes that the places that prescribed the most antipsychotics had higher populations of non-white patients. They had higher male ratios for patients, and it was in areas that had less educated, lower income, and younger residents. The higher prescribing nursing homes also had less intervention from social services and from patient families. A study in the UK had similar results in nursing homes with 4,000 residents on overprescribing and the reasons why they were overprescribing. So they put a whole action plan into place, and they implemented an awareness and education program. They developed a patient-centered approach to care. They established therapeutic activities with higher levels of staff. They tried to change the environment to make nicer environmental settings, and they improved interdisciplinary communication by developing tools, and they regularly monitored and audited prescribing in their facilities. And this step made them reduce their prescribing of antipsychotics to less than 7% of residents, which is a big improvement. And the study basically concluded that reducing antipsychotics in nursing homes is a continuous effort, and it must be monitored frequently, and system-wide processes must be developed to ensure that the trend continues and ultimately guarantees patient safety. Next slide. So now we have discussed all of the risks associated with prescribing antipsychotic medications to patients with dementia. And although there are a lot of risks, there also are not a lot of alternatives. In one study I read, they did discuss cholinesterase inhibitors, memantine, and SSRIs as possible treatments. None of these have been approved, and there needs to be more research done to see if any of them can be as effective as the antipsychotics and have a safer medication profile. In addition to research on development of new drugs that might help these symptoms, the specific antipsychotics also have to be researched. In most of the current literature and studies, they break them into terms of typical and atypical antipsychotics. However, there are a lot of differences between each medication, especially in the newer medications, the atypicals. Each medication has different properties that may make it more suitable, and more research is needed. Next slide. In practice, prudent, thoughtful prescribing must be used when managing dementia symptoms due to the complicated nature of treating these at-risk patients. The goals of prescribing antipsychotics for dementia must be done on a case-by-case basis, using good judgment to target the worst symptoms with the safest medications, or utilizing alternative therapies and not using any medications at all. But before prescribing antipsychotic, clinicians have to weigh all the risk factors for a given patient and consider not only the indications provided by the regulatory agencies, but also the overall effectiveness of the antipsychotics. Next slide.